This is Sheri Stevens. I'm a registered nurse currently in the Family Nurse Practitioner program with Texas A&M University Corpus Christi. My presentation today is an integrated systematic review of literature on decreasing the severity of oral mucositis in patients receiving head and neck cancer treatment. My PICO statement is in patients with head and neck cancers undergoing radiation therapy, does implementation of an oral care protocol lead to a decrease in the severity of oral mucositis? Definition of terms. For those of you that are not familiar, mucositis is an inflammation and/or ulcerative type lesion of the oral cavity that can be both painful and debilitating. Cancers of the head and neck are cancers that begin in the mucosal lining of the head and neck and include cancers of the mouth, nose, and throat. Radiation is an action that uses high energy beams to kill cancer cells. An oral care protocol is a protocol used by clinicians to assess for oral mucositis that contains instructions for patients for at-home self-care. Adverse events include pain, infection, altered nutritional status, and decreased quality of life that sometimes can delay in diagnosis and that can affect speech and compliance with treatment. For my problem statement, there is inconsistency in common practice amongst healthcare professionals in how to assess and treat radiation-induced oral mucositis. A cross-study comparison is made difficult due to a wide variety of assessment tools and treatments. Oral mucositis is very common in head and neck cancer patients who undergo radiation, and lack of effective treatment can cause complications and treatment delays. In conducting my search, I included terms such as oral mucositis, radiation therapy, head and neck cancer, and oral care protocol. Inclusion criteria included a systematic review, research reports, or meta-analysis. Also, interventions for the assessment and treatment of oral mucositis were examined. Articles must be published between 2007 and 2017, and the study includes patients with cancers of the head and neck. Exclusion criteria were articles that did not meet minimum quality appraisal of 3.0, did not encompass treatment of oral mucositis, and articles that were published prior to 2007. My study results, in a search through the Oncology Nursing Society, I resulted with 12 articles, 0 of which were not related, and 0 of which were duplicated. A CINAHL search resulted in 48 articles, 16 of which were not related, and 5 of which were duplicates. A PubMed search resulted in 32 articles, 8 of which were not related, and 10 were duplicates. A National Comprehensive Cancer Network search resulted in 1 article, which was related and was not duplicated. In total, I found 54 available articles for review, 48 of which did not receive greater than 3 quality rating, and I finally chose 4 articles for my integrated systematic review of literature. One study chose 88 subjects presenting with World Health Organization grade greater than 2 oral mucositis. It was a descriptive cross-sectional design. Subjects indicated their intensity and distress of oral mucositis and associated oral dysfunction. The intensity of oral mucositis was significantly correlated with the intensity of the distress score of oral dysfunction. Unfortunately, this did not support my PICO. My second study was of 20 patients who were given an oral care protocol and a nutritional protocol. Data was collected through face-to-face interviews using an oral assessment guide. Grade 1 oral mucositis developed in week 2 in 15 patients in the control group and in 2 patients in the intervention group. By week 7, grade 4 oral mucositis had developed in 1 patient in the intervention group and in 6 patients in the control group. This did support my PICO. My third study was of 100 patients who were randomized to receive either benzitamine oral rinse or a placebo during radiation treatment for head and neck cancer. In the benzitamine group, the frequency of oral mucositis of greater than or equal to grade 3 was 43.6% in contrast to 78.6% in the control group. The median interval to observation of grade greater than 2 oral mucositis was 24 days in the control group and 28 days in the benzitamine group. This did support my PICO. My fourth study was of 22 head and neck cancer patients receiving radiation therapy who were randomized to receive standard pain control with acetaminophen and opioids, or standard pain control with acetaminophen and opioids with the addition of gabapentin. Total opioid use at maximum oral mucositis, as well as 4 weeks post-treatment, was higher in the intervention group of 215 milligrams versus 745.3 milligrams, and 1,260 milligrams versus 1,573.5 milligrams, respectively. Unfortunately, this did not support my PICO. In synthesis, 2 of the articles noted that patient adherence has an impact on outcome when using an oral mucositis protocol. Studies show that varying interventions can have a positive impact, and nursing knowledge was noted to be of importance in patient education. Limitations were noted to be patient adherence to the protocol and change in venue for treatment, as well as nursing knowledge. In discussion, data does show that implementation of an oral mucositis protocol does decrease the severity of oral mucositis in head and neck cancer patients receiving radiation therapy. It is clear through systematic review that intervention greater than the standard of care is necessary. Also, that further research is needed to determine what the best practice interventions should be.